A right upper quadrant scan is a common scan for a sonographer. The scan includes images of the liver, gallbladder, bile ducts, and right kidney. I enjoyed learning this scan. This presentation is images from a RUQ scan I did a while ago. I will be going through the scan as well as critiquing my own images on things I would do differently. The pancreas can sometimes be difficult to image. My head and neck picture is missing a visible GDA and CBD. However, these are not always able to be imaged. Following the splenic vein will guide you to find the tail of the pancreas. Gas was covering the head of the pancreas, but I could have turned my probe more to 7 o'clock to show more of the tail. My aorta could have been more elongated and showed a better connection to the SMA. I could have also showed a better connection to the heart. Using TGC would have cleared out the vessel more. I measured the AO diameter, including the walls in the measurement. Aorta diameter should be less than 3 centimeters. My IVC picture was cleared out well. The left lobe of the liver is taken at different levels. The lateral and aorta levels are shown here. I swept as lateral as possible for my first image. Also make sure your focus is at the level of the liver and you're not clipping the inferior tip. 2 images may be needed. I could have used TGCs to make my image more homogeneous throughout. The liver at the level of the caudate lobe and IVC are imaged next. It was difficult to find the patient's ligamentum venosum, as you can see, but that should be a landmark for your caudate lobe picture. Again, make sure your focus is the liver since that is the main organ we are showcasing in these images. My focus could have been lower for my caudate lobe picture as well. We also imaged the left lobe in transverse at different levels as well. Be sure to show heart at the superior level, ligamentum venosum at your caudate level, and ligamentum teres at your inferior level. I think I could have found a better window to image the caudate lobe here, as well as decreased my depth on my trans left liver inferior image. For the right lobe of the liver, we must increase our depth. In our first image, the gallbladder, portal vein, and main lobar fissure should be shown. The diaphragm should also be bright. I was experiencing some artifact with my machine during this scan, and that is why it looks like it is snowing in the bottom left. I also could have shown a better MLF. The kidney interface image should show just that. The interface between the kidney and the right lobe of the liver. We also measure the liver in this image. Normal measurement should be 13 to 17.5 centimeters. I think my top caliper could have been moved over a bit to give a better measurement of the liver. I also could use TGC to brighten up the far field. The next image is the lateral portion of the right lobe of the liver. We can sweep lateral from our kidney interface image to obtain this. There should be minimal to no vasculature seen and the diaphragm should appear as a backwards J. I did a good job showing no vasculature, however, I could have moved my probe more superior to show more of the patient's diaphragm. In the transverse plane, we imaged the right lobe at different levels. Our dome picture should show heart on the right of the screen and the diaphragm should appear as a U shape. I could have definitely found a better window for my dome image, however, the heart is visible. 2 to 3 hepatic veins should be shown next, along with the diaphragm. I feel like this image is pretty. The level of the portal vein and inferior tip are imaged next. I think I could have elongated this portal vein more. Portal veins are usually horizontal on the screen. I think different harmonics could have brightened up my far field as well. The kidney should be seen in the image on the right. We should check Morrison's pouch for fluid. The gallbladder is first imaged with the patient in the supine position. This patient had a folded gallbladder, however, in the long plane I managed to get the full neck, body, and fundus. You should sector in on the gallbladder to reduce the number of scan lines. You should also turn down your gain to clear out the gallbladder, as well as use TGCs. Make sure you are imaging in harmonics. Next, we have the patient roll onto their left side, called LLD. This may help unfold the gallbladder. Again, sectoring in is a good idea. You also need a measurement of the gallbladder wall. The wall should always be measured on the anterior portion. I am not sure if I am catching the gallbladder as elongated as it could be, and it is hard to tell if I am truly long and transverse on the organ. The common hepatic duct should always be visualized with color on. No color should be seen inside the duct. This proves it's a duct and not a vessel. I should have tried to elongate the CHD in this image. The CHD is also measured. It's measured inner wall to inner wall. The CHD is also intrahepatic, meaning inside the liver. The common bile duct is also imaged with color on to prove it is the CBD. Again, no color should be seen inside the duct. The CBD is extrahepatic, meaning outside the liver. I think this image shows the CBD well. We also measure the CBD inner wall to inner wall. The CBD should be less than 6 millimeters. My right long kidney mid-picture is seen here. I think I did a good job at getting the kidney horizontal on the screen. It is important to try different windows when imaging the kidney. The normal adult kidney measures 9 to 12 centimeters in length. I think I did a good job at elongating the kidney as well. I also sectored in to reduce scan lines and improve image quality. My transverse right kidney mid-picture is next. The kidney should look like a C in this image. You should sector in to improve image quality. I tried to get the hilum of the kidney to prove I am mid. You can also go from your long kidney image and rotate your transducer 90 degrees. Be sure to measure the kidney by cutting it in half. I am also going to review some scanning techniques for scanning the right upper quadrant. Rolling your patient may help slightly move the organs or gas for a better image. A common position is LLD, which is when the patient rolls on their left side. Another technique is having the patient take a deep breath and hold. This will also help slightly move the organs to image them better. Sometimes having a patient hold their breath is helpful. However, sometimes having a patient breathe normally is the better option for the scan. Also, having your patient extend their arms over their head can help open up rib spaces and better imaging windows. When imaging the pancreas, having your patient sit up slightly may help you image the organ. Using your machine to your advantage will improve your images. Using different harmonics will improve your image quality. Also, make sure your focus is always at or just below the organ you are imaging. Always consistently adjust machine controls for each image. Don't just set your controls and go through the scan. Use the heel-toe method to make things horizontal on your screen. Now let's take a short quiz about a right upper quadrant scan. After the question, you will have 3 seconds before the answer will appear on the screen. What vessel helps you identify the pancreas? What is the normal aorta diameter? What landmark do we use for our caudate lobe picture? What 3 landmarks should be in our long right liver medial image? What does the normal liver measure? What pouch should we check between the kidney and the liver? The gallbladder wall should be measured on which side? What tool do we use to prove we are imaging the CHD and CBD? What does the normal adult kidney measure?